Okay, let's imagine this. You're the resident on call, right? Trauma bay doors swing open, high energy ankle injury, and the x ray pops up. Boom, Talar neck fracture. Suddenly, all these questions start racing because, well, this isn't just any old break. It's potentially a real minefield. So today, we're going to navigate that minefield together. This is our deep dive. We're aiming to turn, complex anatomy and classifications into a clear strategy for the real world and maybe more importantly right now for those FRCS exams or similar fellowship tests you're prepping for. And just so you know, our whole chat today, it's based on the fantastic Ortho Made Simple notes over at mokyingren.sg. They were put together by Dr. Mok Ying Ren, who's a sports surgeon at National University Hospital in Singapore, got his FRCS back in 2022. Super sharp stuff. Our mission here is simple. Distill the essentials, find those surprising insights, and really equip you with the understanding you need. For exams, yes, but also just for being a better clinician. It's about getting that knowledge quickly, but, properly. Connecting the dots and getting those aha moments. So let's kick off with the big question. Why the talus, specifically the neck? Why is it such a notorious player in orthotrauma? What makes it so darn prone to things like a vascular necrosis, AVN after it breaks?
Yeah, that really is the fundamental question, isn't it? And what's fascinating, or maybe frustrating depending on your perspective, is that its own anatomy kind of sets it up for trouble. I mean, think about this. Over 60% of its surface covered in articular cartilage. Now, cartilage is great for smooth joints, obviously.
Right.
That means there's less actual bone surface for soft tissues to attach to, and crucially, less area for blood vessels to really get a good hold and penetrate. That right there limits its blood supply potential.
Okay, so less surface area for vessels. What else?
Well, unlike most other bones, the talus has almost no muscles attaching directly to it. And that's a
Yeah.
huge point because muscles usually bring a really rich blood supply with them, that collateral flow. The talus just misses out on that. But here's where it gets really interesting and maybe a bit counterintuitive. Its blood supply is largely retrograde.
Retrograde blood supply. Okay, we hear that term a lot. But can you break down why that makes it so vulnerable? It almost sounds like it's designed to fail if you fracture the neck.
It kind of is, in a way. Imagine the talus is like a building, and the main water pipe doesn't come in through the basement or the ground floor. It comes in through the roof, and then has to snake all the way back down to supply the lower floors. If you fracture the neck of the talus, it's like cutting that pipe right where it enters the roof. You disrupt the supply before it even gets to the main part of the bone.
Ah, okay. Starving everything downstream.
Exactly. You're starving the main body of the talus. It's just fundamentally different and more precarious than bones that get blood flow from multiple directions or more centrally. This whole setup just makes it incredibly susceptible to ischemia if you injure that neck.
So, given how fragile this supply is, what are the actual lifelines? Which arteries are trying to keep this bone alive? How does it get its blood?
Right. And understanding these specific pathways isn't just academic, like you said. It really directly impacts how we plan surgery and what we tell patients about their prognosis. It's practical stuff. So the talus gets blood from, well, a network. From the front, you've got the anterior tibial artery, the ATA, which continues down as the dorsalis pedis. It plays a role. But the real workhorses, the ones often providing that crucial backup supply, are branches from the posterior tibial artery, the PTA. Now, the PTA gives off a couple of really important branches. There's the tarsal canal artery. But the one we really focus on clinically, the sort of superstar for keeping the talus viable, is the medial deltoid artery.
Ah, the medial deltoid artery. Okay, now we're getting into surgical strategy,
Yeah.
right? Like the medial malleolus osteotomy you sometimes hear about.
Precisely. That artery runs within the deltoid ligament on the medial side, the inside of the ankle. And here's a really key insight, something that can seem backwards at first. Doing an osteotomy, cutting bone, normally means more trauma, right? But for these specific fractures, a medial malleolus osteotomy, or MM osteotomy, can actually be a preservation technique. It's a deliberate cut, planned specifically to avoid damaging that deltoid ligament, which houses this critical artery.
So you cut the bone to save the ligament and its artery.
Exactly. You carefully lift the piece of the malleolus with the ligament attached, protecting what might be the last significant blood supply getting to the talar body. Preserving that pathway is, well, vital. And then let's not forget the perforating peroneal artery, the PPA. It contributes quite a bit too, especially supplying the sinus tarsi artery on the lateral side. So you've got this delicate mix of supplies coming from different directions, all trying to feed a bone that's already, prone to vascular issues. Any big disruption, especially right at the neck, can be catastrophic.
It's so clear that blood supply is just absolutely critical, like you said, a sword hanging over these injuries.
Okay, so given this delicate map and the inherent risks, predicting complications is huge. And for that, we lean heavily on Hawkins classification, right? This seems like where things get really practical for predicting outcomes in treatment.
Absolutely. Hawkins is the cornerstone. It gives us a systematic way to think about the risk of AVN based purely on how displaced the fracture is and which joints are involved. It's essential for talking to patients about what to expect and honestly for deciding how urgently you need to get to the OR. Examiners love asking about this too.
Okay, walk us through it, type by type. Right. Let's break it down, focusing on the displacement and that all-important AVN risk percentage. Type 1, that's your undisplaced fracture, minimal disruption. Here, the AVN risk is pretty low, relatively speaking, around 10%. The blood supply is mostly okay. Type 2, now things get more serious. This is a displaced fracture with subtalar joint involvement. The AVN risk jumps way up, somewhere between 25% and 50%. And this is where the value modification is super important. It's a key nuance. Value split type 2 into 2A and 2B.
Okay, what's the difference there?
Big difference in outcome. 2A is where the subtalar joint is just subluxed, kind of partially separated. Surprisingly, Valier found this carries basically a 0% AVN risk. But 2B, that's where the subtalar joint is fully dislocated, completely separated, and that pushes the AVN risk up towards 25%. That distinction, subluxed versus dislocated, is critical.
Wow, 0 versus 25%. That's a massive difference based on what might seem like a subtle distinction on the X-ray. So partial separation isn't necessarily cutting off the blood flow like a full dislocation does.
That seems to be the idea. The thinking is that a full dislocation implies much more tearing of the surrounding ligaments and, crucially, the small vessels within them. The degree of soft tissue disruption matters. Okay, moving on. Type 3 is a displaced fracture, now with tibiotalar joint involvement as well. This is a major injury pattern. The AVN risk here skyrockets to around 90%. And then, the worst-case scenario, type 4, that's a displaced fracture involving the talonavicular joint too, so tibiotalar, subtalar, and talonavicular. Here, the blood supply is almost certainly compromised completely. The AVN risk is basically 100%.
It's really striking, isn't it, how clearly the classification maps onto the risk of AVN, one of the complications we fear most.
It really is. It just underscores that fundamental principle. More displacement, more joints involved equals more vascular disruption. It's high-yield stuff, absolutely essential for exams and for that initial assessment in the ER or clinic.
That direct link between displacement and AVN risk is, yeah, a powerful predictor. It guides everything. So, okay, you've diagnosed it, you've classified it using Hawkins, maybe even Valier's mod. What's next? How do we actually manage these things definitively? What's the guiding principle?
The guiding principle always is thinking about both patient and injury factors. You have to consider both sides. On the injury side, well, if you've just spent time talking about it, high AVN rates, the potential for the talus to collapse later on, and that looming risk of osteoarthritis, especially in the subtalar joint. These aren't just immediate problems, they affect patients long-term. Then on the patient side, you absolutely have to factor in things like peripheral vascular disease, PVD, or diabetes mellitus, DM. They complicate everything.
Right. How exactly do those patient factors change what you might do?
Good question. Let's say you have an older patient, maybe poor circulation from PVD. You might lean towards external fixation initially, just to stabilize things without a big incision right away, minimizing risks to already compromised skin, or a patient with diabetes. You're going to be hypervigilant about infection, maybe more aggressive with wound care, timing the surgery even more carefully. It adds layers of complexity. So our main goals: standard fracture stuff, get it lined up anatomically, fix it stably. But there's a crucial added goal here: preventing varus malunion.
Varus malunion, explain that a bit more. Why is that specific deformity such a focus?
Varus is where the foot turns inward relative to the ankle. It's a really common way for these fractures to heal incorrectly if you're not careful. And it's debilitating. It throws off the whole biomechanics of the foot and ankle, puts abnormal stress on joints, and basically guarantees painful arthritis down the road. So actively preventing varus during surgery is paramount.
Okay, makes sense. So factoring all that in, patient injury goals. Let's talk hardware. What are the practical options for surgical fixation? The ORF itself.
Right, for the ORIF, screws are definitely a mainstay. You've got choices. Anterior to posterior screws or posterior to anterior depends a bit on the fracture lines and what works best. But critically, we almost always use multiple headless screws. Why headless? Remember all that articular cartilage?
Ah, right, 60% coverage.
Exactly. A standard screw head sitting proud on that cartilage would just chew it up, causing pain and more arthritis. Headless screws sink within the bone, holding it together without messing up the joint surface. Now, if the fracture is really smashed up, lots of small pieces comminuted, then we might think about using mini fragment plates. And specifically, putting a small plate on the medial side can be really helpful. It acts like a buttress, directly fighting against that tendency towards varus collapse we just talked about. It physically stops it from falling into varus.
So you're actively building a construct to prevent that specific deformity.
You are. In the OR, you're constantly thinking about preventing varus. It's not just about getting the pieces together. It's about anticipating how they want to collapse and stopping it. Sometimes we call it fighting the deformity.
It really sounds like it's as much about understanding the forces in the blood supply as it is about just putting screws in. Okay, so how do you actually get there? Safely and effectively. Surgical approaches.
Yeah, getting exposure is key, and doing it safely. The big consideration is often using a dual incision approach, one medial, one lateral, to see everything well. And you have to be hyper aware of the nerves and vessels. Specifically, watch out for the superficial peroneal nerve, SPN, laterally, and the saphenous nerve and vein medially. Damaging those can cause real problems. So the two main approaches we use are, first, the anteromedial approach. This one runs just medial to the tibialis anterior tendon, kind of aiming down towards the first metatarsal. The beauty of this one is it naturally avoids the main dorsalis pedis neurovascular bundle, because that bundle sits lateral to the tibialis anterior.
Okay, that's clever positioning.
It is. And then second, the anterolateral AL approach. This one goes more between the tibia and fibula, aiming towards the fourth ray. You have to lift up the extensor digitorum brevis muscle. But the big warning sign here, flashing red light, is watch for the SPN. The superficial peroneal nerve is right there, very vulnerable. Injury leads to numbness on the top of the foot, sometimes painful neuromas. You have to find it and protect it. And just to circle back, remember that medial malleolus osteotomy we discussed. That's often part of the exposure. Again, sounds counterintuitive to cut bone to get better access, but the goal is preserving every last bit of blood supply, especially from that deltoid ligament. It can be critical.
It really drives home how vital that detailed anatomical knowledge is for you as residents. It directly impacts outcomes. Okay, surgery's done, fixation looks good. What happens immediately after? Post-op care.
Immediately post-op, it's usually a back slab, just a posterior splint for comfort and protection, and absolutely non-weight-bearing NWB, usually for a good 6 weeks. NWB is non-negotiable here. You need to protect that delicate fixation and give that tenuous blood supply the best chance to recover without the stress of weight going through it. Then, in follow-up, we're watching the x-rays closely, and one really specific thing we look for is something called Hawkins sign.
Hawkins sign. Okay, I remember this one being a bit confusing initially, because it involves bone resorption, right? Can you explain why seeing bone disappear is actually a good thing here?
Yeah, it's a classic point of confusion, but it's a fantastic aha moment when it clicks. Hawkins sign is basically this little sliver of bone resorption you see right under the cartilage dome of the talus on an x-ray. Usually shows up around 6 to 8 weeks after the injury. And what's fascinating, and seems backward, is that this sign, this resorption, is actually a positive indicator. It means that the bone is alive. It signifies viable bone undergoing remodeling. It's thought to be a feature of neoangiogenesis, new blood vessels forming. It tells you blood flow is returning to the talar dome.
So seeing that subtle resorption means the bone isn't dying from AVN.
Exactly. It's a strong sign that the bone is healing and not developing a vascular necrosis. Conversely, if you don't see Hawkins sign develop by 6 to 8 weeks, that's when you start getting more worried about AVN.
Okay, that's a critical distinction. Definitely something to remember for exams in clinic. So even if the surgery goes well, Hawkins sign appears. What are the long-term complications residents need to counsel patients about and watch for?
Yeah, unfortunately, even with the best surgery, the initial injury takes its toll. Long-term issues are common. Subtalar osteoarthritis, OA, is probably the most frequent. That study by Valier et al. Found in over half the patients, 54%. If that OA gets bad enough, painful enough, then fusing the subtalar joint is often the salvage procedure. It helps the pain, but you lose that inversion-aversion motion. A vascular necrosis, AVN, of course, remains a risk, even if Hawkins sign was present initially. Sometimes it develops much later, leading to collapse of the talar dome and joint problems. And that varus malignum we talked about preventing, it can still happen, or maybe a mild version occurs. It remains a persistent concern because of how badly it affects function.
So managing these isn't just about the initial fix.
Not at all. It really raises the important point about long-term management and patient counseling. You need to be upfront with patients. This isn't just fix the break and you're done.
Yeah.
It might mean managing arthritis for years, potentially needing more surgery down the line, like a fusion. It impacts their ability to return to sports, maybe even their job. Requires diligent, long-term follow-up, sometimes for many, many years.
That's a really important perspective shift. It's managing a condition, not just an acute fracture.
Wow. Okay, this deep dive has really highlighted that complex interplay, hasn't it? Unique anatomy, the classifications, the surgical nuances, post-op signs like Hawkins. It all ties together. This is exactly the kind of focused knowledge that builds real confidence for exams and for when you're facing this in the OR or clinic. And as you're processing all this, maybe think about this. How does understanding the talus, with all its quirks, frame how you approach risk and other complex orthopedic injuries? How can you apply this kind of systematic thinking elsewhere? And, as you continue on this demanding path, studying hard, serving patients, striving for excellence, it's good to remember some timeless wisdom. Proverbs 11:1 says, "Whoever is steadfast in righteousness will live, but he who pursues evil will die." May you be blessed with wisdom and discernment in your studies, in your practice, always aiming to heal and serve with real integrity.
Couldn't agree more. This deep dive was powered by those incredibly useful Ortho Made Simple notes, which you can find at mokyingren.sg. Definitely check them out. Until next time, keep digging deeper.